ladies and gentlemen, if you'd like to take a seat, please. Ladies and gentlemen, a distinguished guest. Welcome to this special Devex event coming to you live from Neuhaus, Madison Square, New York City during UNGA 78. My name's Richard Jones, Editorial Director at Devex. I'm delighted to welcome our in-person and online audiences from around the globe for this special discussion on how we can deliver global health impact for all through partnerships. So first and foremost, I'd like to give a big thank you to our partners at GSK for powering this event. And yeah, ladies and gentlemen, if you'd like to fill it from the front, that's great. We're about to get started. So as the old saying goes, prevention is better than cure, especially in low-income country settings. One of the most successful and cost-effective public health investments in prevention has been immunization. However, in many countries, decades of progress on immunization coverage is now under threat, following setbacks precipitated by the COVID-19 pandemic. Globally, just to put this in context, globally, 1 in 7 children are zero dose. That means that they've not received any routine vaccinations. So what can be done to reverse course? Well, with an eye on the 2023 UN high-level meeting on universal health coverage coming up, in the next hour, we're going to be hearing more about the need for preventive primary care to improve health outcomes for all. And we're going to hear more about the role of immunization strategies, research and development, and the role of partnerships in unlocking the power of prevention in low-income country settings. We're also going to hear about lessons learned from a special partnership celebrating its 10th anniversary. So without further ado, let me hand over to my colleague Anna Gavel, who's Devex's managing editor, and our esteemed panel. Thank you very much. Anna, this one to you.
We'll get everyone up on stage all together, save a bit of time, but please welcome to the panelists. One, two, three, four. Yes, just making sure we have enough. All right, well, thank you, everyone. Thank you, Richard. And of course, thank you to our panelists today that we have. Let me get some introductions. We have Dr. Awad Mataria, who is Director of Universal Health Coverage Health Systems for the World Health Organization's Regional Office for the Eastern Mediterranean, where for the last 10 years, he's been supporting countries in the region to reform their health financing systems to move toward universal health coverage. Welcome. And we also have Thomas Breuer, who is Chief Global Health Officer and Senior Vice President for GSK, having previously worked in the GSK Vaccines Division. Board certified in internal medicine, Dr. Breuer had a 6-year career in patient care before working at the U.S. Centers for Disease Control and Prevention and German Public Health Institute in Berlin. And we also have Neha Agarwal, who is the Global Program Director, Co-Director of Diagnostics at PATH, before which she held positions at the Clinton Health Access Initiative, Applied Strategies, and companies such as Johnson & Johnson. And last but not least, we have Thabani Mafosa, who is Managing Director of Country Programs Delivery for Gavi, the Vaccine Alliance, overseeing Gavi's operations in 73 countries. Prior to joining Gavi, he held several leadership roles in World Vision International for over 16 years. So we have quite the esteemed panel, and I want to go ahead and dive in. Let's start with a question for everybody. As you well know, the COVID pandemic led to the largest continued backslide in childhood vaccinations in 3 decades. What's needed to ensure routine immunization services can withstand these types of shocks in the future? Dr. Watt, can we begin with you?
Well, thank you. Thank you very much, first, for hosting me and for this very important question. Because while the world has been trying to look at the consequences and how to mitigate the negative impact of the pandemic through very strict and severe measures, rightly so, at the beginning of the response to the pandemic, we start to notice that countries are suffering from an interruption in essential health services, including vaccination, but also other types of essential health services. And that had an impact really on the health and well-being of individuals, but also in particular on children. This is when, as the WHO, we started looking at how to ensure the continuity of essential health services while we continue to respond and to mitigate the impact of the pandemic. So if you recall, we had developed the strategy to respond to the pandemic. After a few months of the implementation, we added a pillar in particular to focus on essential health services, including vaccination, including maternal and child health, but also to pay attention to non-communicable diseases. Now, since from the learning that we have been gaining, we have really learned the lesson the hard way at a very high cost, that we cannot separate discussion on health security from discussion on universal health coverage. So the agenda moving forward is how to build resilient health systems that would advance the dual agenda of health security and universal health coverage. And this is what we have been working on in the region. So last October, we presented to our member state a regional strategy of 7 agenda points on how to build the foundation of a health system with a focus on essential health services, focus on essential public health functions, but also to build the right institutions to ensure that we continue to deliver on what is needed on the essential health services while continuing to address and mitigate any type of emergency. And for us in the Eastern Mediterranean region where I am based, so we have different types of emergencies. So we're not only talking about outbreaks and pandemic. We are a region, unfortunately, that is hit by many types of conflicts, internal conflicts, but also occupation and so on and so forth. And we are on the news for the last couple of weeks with the multiple unfortunate environment-related emergencies, the floods in Libya, but also the earthquake in Morocco, and so on and so forth. So what we are trying to do from a health system point of view is to ensure that there is one health system, and basically there is one health system for every country, and that health system is catering for all types of hazards related to pandemics, outbreaks, hence the importance of vaccination, but also the other types of hazards that the country is faced with. And so we have now is 7 agenda point that I can further dwell on to build the resiliency in the health systems moving forward. Thank you very much.
Thank you. And Thomas, what are some of your thoughts in terms of what we can be doing moving forward?
My colleague from WHO already covered quite a range. Maybe just to mention one thing, this was obviously a major event. Hopefully it will not be repeated anytime soon. But for me, the main point is take the learnings out of it. So we saw, for example, at some point too late, but COVID vaccine was available in the country, but then could not be adequately distributed. We also saw that personnel was removed from existing implementation programs and put to deal with the COVID pandemic. So I think everyone, or a lot of people, a lot of organizations have the tendency to move on to the next problems, but pause and reflect and take the learnings out of it so we will be better next time.
And there's certainly a lot of lessons we can learn. Neha, what about you?
Yeah, I think for lessons learned carrying over, one of the key ones is that market failures already exist in normal times, and those were extremely exacerbated by the pandemic. And one of the biggest gaps that we saw was in the rate of vaccinations in other parts of the globe, in addition to access to medical commodities. And so we really need to think about how do we ensure low and middle income countries have access to basic health, essential diagnostics, devices, vaccines, pharmaceuticals, in a way that allows them to be more autonomous and more resilient. And one of the key questions is around how do we transition aid into actual investments? So investments in capacity building, investments in local manufacturing, and that should be a tool that we continue to develop and we don't forget just because we're trying to move on.
Bonnie, what about you?
Thank you. I think I'll come at it in a complementary but different way. I think we talk about universal health coverage and primary health care, and they're important from a systems perspective. But I would like to talk about them being important from a people perspective. And the reason I talk about the people perspective is that when I look during the pandemic, some of the governments that struck it the most were the ones that had their frontline health workforce weak. And if we don't take this opportunity to really invest in community health, but in frontline health workers, we would have missed a significant opportunity. When you think about whether it's a pandemic or an outbreak, it never begins in a diagnostic lab. It actually begins at a community level. It is first identified by those who are in the front line. And so the skill sets of the people who are in the front line becomes extremely important as part of a solid primary health system. Let me give you an example. I just came from Nigeria this past week. They have one of the biggest diphtheria outbreaks at the moment. And when I was talking to people there, one of the things is that it took weeks for people to actually understand that this was diphtheria, because there was no one who had actually witnessed diphtheria before in a long while. So this was an outbreak of a disease that people had not seen in a long time. So the skill sets of our frontline health workers, how they are tooled, is important. And another example is the standard operating procedures for some of our frontline health workers. In some countries, they haven't been updated in 20 years, in some in 15 years, but it's been a long time, and there's been a number of things that have been added into the health system that people are not actually equipped to deal with. But you can get me started with people, but I'll stop there for now.
Well, I'm going to stay with you now. And for my next question, I mean, you talked on that note about community, and then in general, when we're talking about vaccines, obviously with the COVID-19 vaccines, there was mistrust between the so-called global north and the global south as wealthier countries bought up these vaccines. How has that impacted other vaccine partnerships? And what are your thoughts on shifting, let's say, manufacturing and IP know-how to the global south as we move forward with other vaccination campaigns?
That was two questions.
That was. So I'm a journalist, we sneak them in like that.
I'll try to break them down so that I respond to both of them appropriately. On the first one, you know, I've always said that language matters. And when I think about vaccine confidence, vaccine hesitance, it's a spectrum. And sometimes it's very easy to run to the extreme of the spectrum. What we saw with COVID vaccines was what I would probably call a borderline vaccine confidence, vaccine hesitance issue, but not a full-blown vaccine hesitance. But I also want to bring the issue of how we live in an interconnected world. We had a certain country that shall remain unnamed in Africa. And that country is a former colony of a certain country that also shall remain unnamed. But colony and colonizer, and one of the things that actually happened here was that there was significant vaccine hesitance and confidence issues in the country that colonized. And you'll be surprised. That country said, how can we trust these vaccines when our colonizers don't trust it? Even today, vaccine confidence transcends borders and is influenced by what happens across the board. And what then happened is that we had vaccines that arrived at that country, but we ended up having to move them from that country because they said, well, if country X is not accepting them, why are they being given to us? But what was also really interesting at that very time is that Europe took a decision to put some travel bans to some African countries and not recognize certain vaccines. And so these contradictory behaviors left people saying, why should I be taking a vaccine that cannot actually allow me to travel to the other part of the world. There must be something they know that I don't know. So political behaviors and the confidence that they engender is something that has got to be watched out for. You cannot behave in one way and assume that the world is not watching. It translates and crosses across borders. I'll move to your second question because I could have been longer on that specific question. On your second question, IP vaccine manufacturing, I think the pandemic has really put Africa on edge. Africa has never felt so left alone. You know, when I met with John Kengasong, Dr. John Kengasong, he said that this happened to us during the HIV pandemic period. It's happening again. And how many times is it going to happen to us? If it happens once, you say it's an accident. If it happens twice, really when it happens the third time, you are a fool. So Africa is waking up and it is saying it cannot remain foolish on its global health. And so I think it is calling up and there is a shift on the need for vaccine manufacturing in the continent, and Gavi believes it is the right thing.
It's a shift we've been covering regularly at Devex, and it's been a fascinating evolution. So thank you for answering both of my questions that I snuck in on you. But I wanted to shift gears maybe to a different part of the world. So Awad, you work in some of the toughest countries on the planet. Conflict, humanitarian crises, some cultural opposition to vaccinations. You're talking Afghanistan, Somalia, Yemen. Where have you seen progress in the face of such challenges? And what are some of the biggest barriers you've had to overcome?
Yeah, no, thank you very much for nicely describing the region where I come from and where I serve. Unfortunately, this is the reality on the ground that has been there for decades, if not longer than that. There are different types of challenges that we are faced with. One of the key ones that we have really during the pandemic, but also continuously during all the type of works that we do as WHO, is that division within the same country, and division not only territorial but within the government. So you would find different governments managing different parts of the country. And when we were communicating during COVID or other things, you don't really always have one single counterpart with whom you would deal for a national agenda. That has become very, very obvious during the pandemic. So in countries like Libya, like Yemen, Syria, that division did not allow us to have strong leadership in addressing the pandemic. And it became very obvious for us that any effective response to vaccination, but also to implementing and imposing public health measures, requires a decisive leadership. It requires leaders who are able to convey the message and to be trusted by the communities where they are. And that did not happen. I mean, my colleague has been referring to colonizer and colonized, but also within the country, when there is political division, that has happened unfortunately in many of our countries of our region. I think one of the key lessons, and that is something that I'm taking very closely on the agenda of health system recovery, health system rebuilding from the pandemic, moving from the pandemic, is the importance of bringing community at the center of health system. If you look at even at our WHO framework for analyzing health systems, you don't see community. It is very much provider driven. It is based on a service that is provided, financed, governed, information system around that, so on and so forth. Now, in our new thinking is how to build the trust by bringing communities at the center. We have been talking about person-centered healthcare or person-centered service delivery, but that was only at the service delivery side. We'd like to see individuals and communities part of developing a vision, developing a policy and a strategy before being involved in its implementation. That's why many of our countries now, especially after what has happened during the last decade with the political transitions, are engaged in societal dialogues, in social dialogues with the communities to build that trust. I read an article during the pandemic that came out in the Lancet that was very, very telling for me. I think somebody was saying that the most powerful lesson that we learned from the pandemic is the importance of trust. Trust in science, trust in government, trust in decision makers, trust in the strategies and policies that we want to implement. And the second message is that trust cannot be built during an emergency time. It should be built during a stable time. That's why engaging with communities, making individuals, hearing the voice of individuals and societies while you are developing your policies, strategies is very, very key. And that should be done before, God forbid, any eventual emergency. And unfortunately, these are happening frequently. So we have to invest in the institutions that will allow the voice of individuals and communities moving forward. Again, this is how we are shifting our whole approach of health system recovery, health system rebuilding, and hopefully we'll have a more resilient and equitable health systems moving forward. Thank you.
Building trust during non-emergency times. It's an excellent point. So I wanted to stay on the subject of challenges and barriers. So Thomas, vaccinations are recognized obviously as feasible, cost-effective public health interventions for reducing the burden and associated mortality of so many infectious diseases. What are the current and most pressing barriers for vaccine programs, and what makes it such a challenging public health issue to tackle?
Obviously, it's multifactorial. Maybe to start with barriers above country. Let's get funding out of the way. Funding is always a problem. Gavi is doing a wonderful job in finding the money and then work with UNICEF to distribute many, many vaccines around the world. But there are other vaccines which we all would like to implement, and money is short. From a manufacturer point of view, long-term planning on supply and demand is very, very important. So the earlier we know when things are happening, the better we can plan. And planning on supply and demand is a multi-year effort. It doesn't happen from one day to the other. So when I come now into the country level, obviously one shoe doesn't fit all. The things are multifactorial. Again, budget is one thing. How much to invest in preventive medicine? How much of that money goes into vaccination? And then reaching the populations. We have touched already on this. Countries have varying infrastructures to reach people. In every country, there are populations which are hard to reach or never be reached. And sometimes when we talk about children who do not get any vaccine, we talk about zero-dose children. And I think in the next session, we hear more about that. Another aspect is changes in vaccination populations. So many of the vaccines which are distributed to UNICEF are for infants and toddlers, but there's the HPV vaccine, which is already in another age category. The TB vaccine will go into phase 3 trial next year. If that vaccine is successful, it will be again in another age group, which creates problems. And maybe the last thing, just to repeat, from a patient or parent point of view, knowledge about what vaccines can do, the benefits of vaccine is obviously important. And hesitancy, I was naively believing when COVID happened and vaccine brought a solution to the world that hesitancy would go down. It didn't happen. So hesitancy in one shape or form will always stay with us. So these are the points which are barriers above or within countries.
Thank you. Neha, now let's go beyond immunization. What other aspects of preventative primary care, healthcare, must be guaranteed to truly achieve universal healthcare? What are some of the greatest gaps there?
Yeah, thank you. And thank you to Devex and GSK for making room on the panel to talk about diagnostic and screening. I think that is one of the key tools that we have underutilized and sort of underappreciated when we think about primary health care and universal health coverage. Just as an example, the recent estimates indicate that about half of the world has access to essential diagnostics, and that number goes down to roughly 20%. So 1 in 5 patients who are living in low and middle income countries. So if we think about just fixing the diagnostic gap, just closing that gap alone and making no other investments, we have the ability to avert 1.1 million deaths per year. So there's a huge, tremendous amount of health impact that could be made by closing that diagnostic gap. But my panelists also talked about hesitancy and trust. And this is where I feel really strongly about the power of screening and early diagnosis. When a patient enters the healthcare system, particularly in low and middle income countries, they have decided to make an investment in time and resources in getting themselves to a health clinic. It now becomes our responsibility to ensure that patient has access to high quality, accurate, timely information on their health. And this is really where the power of screening and diagnosis has a critical role to play in being able to enhance trust between patient and provider, increase confidence so that they feel like they can come back, that they can re-engage when their child is feeling ill. They can come and have a trusted partner to manage their health of themselves and their family. And when we think about, universal health coverage, you can't get there unless people trust the system and that we get over the hesitancy in people even accessing. So I think that this is a key gap that we really need to sort of centralize around, in addition to all the other suite of services around preventative primary health care.
Thank you. Thabani, do you think, are we observing any signs of recovery in vaccination numbers, and what potential long-term effects can we expect unless this trend is reversed?
Thank you. I would say that we have a mixed story. Each country is following a slightly different trajectory. At the aggregate level, we haven't recovered to the baseline of 2019. If we use 2019 as a baseline, we have seen some improvement. It's about 3%, but it would have set us back to a space where we call it a recovery if it had been 5%. So we are still 2% lower than where we should have been. We've seen some countries like India that have really recovered very strongly. We, on the other hand, have seen countries like Angola that are persisting to be challenged and to have struggles. Then we have a whole set of countries in between, particularly the ones in the fragile and conflict environment, that their data is somehow not able to tell us a full story because the data is not always up to date. You can have a sense that directionally we may be making progress, but by what magnitude, it's a concern. I think in terms of what we should expect, it's already happening. The impact of low coverage in terms of vaccinations. When you see a diphtheria outbreak, you must know that your coverage has gone low. It's not a typical type of an outbreak that would normally get, and unless we have coverage that is low. But measles, we have about 30 measles outbreaks, 10 more than where we would have been in the past. And they are getting bigger as well. But I must also add that climate has not been helping us here. We have seen cholera wreaking havoc in the past year. You think of Pakistan, you think of Malawi, you think of Mozambique, Zambia. We have had Lebanon. Lebanon had not had an outbreak of cholera in so many years. So we are seeing outbreaks that we have not seen in a long time coming back. And if we don't stop the tide, obviously we will be in trouble. That's why under IA 2030, which I used to co-chair, we commissioned the Big Catch-Up. And the Big Catch-Up is meant to catch up those children that were missed. But it also recognizes very small technical issues that can be a barrier at a country level. And one of these things is when you are catching up children, what is the age that you catch up? We have been asking countries to adjust their policies so that instead of catching children of 24 months, they go up to 5 years. And some are even expanding it a little bit more than that. That is quite important. But one thing that I have noticed is that our frontline health workers, without a directive and a change in policy, they will not. A child will show up. If they are above 24 months, they will tell them go back home, unless and until there is a change in directive at a policy level. So it is important that governments create those policies, and WHO has been doing a good job of making sure that technical assistance is provided to make sure that some of those things are done.
Thank you. So I know we're running close on time. Just to wrap up, we obviously, everyone here has a very, very busy week at UNGA. And then we always have to ask what happens after UNGA. So just a few words each of what you do hope to see happening after this week ends. Awad, perhaps we can start with you.
Yeah, no, thank you very much. I know it's a busy week, and it's great that we are bringing in the health agenda very promptly, very strongly into the UNGA discussions with 3 high-level meetings. I think for me, again, linking it with the question of the pandemic and the learnings, the most important thing for me is to break the cycle of panic and neglect. So during the pandemic, we were all worried. We have accepted things that we would not have never accepted. But the way that I'm seeing it is that as human beings, it's easy for us to forget, as if nothing has happened, and we are going back to our previous practice. So how to keep reminding ourselves and others of the lessons that we have learned. And my second maybe key message from the discussion is that vaccination is very important. I'm a health economist by training. It's the most cost-effective public health intervention that the world has ever known. But vaccination alone is not enough. It should be part of the primary healthcare approach. I mean, we know it in countries like Yemen, like Sudan, like even middle-income countries in our region, that if families and children are coming for vaccination and you don't provide them with other essential health services, it doesn't help. So we have to have the primary healthcare approach, which is with its 3 components now. We talk about primary care, essential public health functions, community engagement, and multisectorality. So to think about the primary healthcare as the foundation of rebuilding our health systems towards equity, towards resilience, moving forward. And I hope that our policymakers, our politicians, decision makers would take that very seriously moving forward from UNGA this year. Thank you very much.
Thank you. Thomas, what would your call to action be?
You know, this week is the United Nations General Assembly, but I'm sure if I would ask for people raising their hand who's actually participating, it will be a very small group of people. So what is really, really important is what is happening around the United Nations General Assembly. And it's just amazing how many people from different organizations you run in, you cross-fertilize. And, you know, since I'm coming from the infectious disease field, if this cross-fertilization happens and you go home with different ideas, different contacts you have made, I think we have all gained a lot.
Neha.
I'll build off of that. I think that the world is moving far too fast for even bilateral partnerships to be sufficient. And so I think we've done a really great job of looking at partnerships, but how do we expand them? How do we truly cross-fertilize? How do we make them more multi-sectoral? We have to sort of learn and move away from the bilateral partnerships, which we're all good at this point, and really think about how are we bringing the different sectors, public, private, academic, corporate, to the table to solve the world's more pressing needs.
Devani?
Sure. I think my colleagues have really covered it well. I think if there is anything that we all gain here is the interchange or the exchange of ideas and learning, and the things that are actually happening outside the UNGA itself, the side events and the things like that. I think that's where there is the richest learning, because in the UN General Assembly there is a lot of reading of statements, but in the exchange that's when we learn the most. But for Gavi specifically, I think that we are going to Gavi 6.0. which is our next strategy. And as I'm engaging, I'm listening very much to what are the ideas that we should be taking to Gavi 6.0. And I think that the health community has been missing on the climate agenda. And it's important for us to think about how do we show up on that agenda and how do we contribute, but also conflict and climate go together as well. How do we show up in those spaces? So I'm obviously thinking into 2030 and how we bring down the number of zero-dose children embedded in the primary healthcare system. Thank you.
Now, I wanted to switch over to the audience. I do want to welcome, we have audience member Dr. Ayan Shankar Seo. He is head of health and nutrition for Save the Children Nigeria. I believe he was on virtually. There we go. Hello, Mohammed. Thank you for being with us. Ayan, I'm so sorry, Dr. Ayan Shankar Seo. You didn't hear that mistake that I made. Any thoughts on the discussion that we've just had on the importance of preventative primary health services and where we stand on that post-pandemic?
Thank you. Thank you for having me. And it was really interesting to hear this distinguished guest's discussion. It's very insightful. And as the panelist is talking about, I have really little to really add to it. But I would say that when I'm working in Africa, definitely in Africa regions, we have different challenges than the rest of the world. And we need a really comprehensive support and strategies to address those, which will not be applicable to other areas of the globe. So we have to see the challenges in Africa in their own way. But definitely, as I got the chance to really interact with this panel, I definitely want to have some understanding and have their view on some of the points. There are lots of discussion about challenges and barriers, but I will again revert back to that arena, considering the potential impact of the deeper collaborations with the private sector would have on the preventive health and health outcome in the low and middle income countries like in Africa. What particular challenge or barrier to this would this panelist most likely to see addressed in this period?
Did anyone want to pick that up? Sure.
No, I think thank you very much for this, especially for bringing in the question about the private health sector. Again, something that we have learned from the pandemic, that it cannot be only the public sector, let alone the Minister of Health, to be able to cater for the health crisis, health challenge like that. And the same thing is valid during normal times. So in in the region where I serve, we have a very big agenda on engaging the private health sector. And engaging the private health sector does not mean privatizing health. We have a 3 agenda points. The first one, to start by understanding the private health sector. We don't always have information about who's practicing in the private health sector, what is its contribution, how much is being spent. Well, how much is being spent on health economists, as I mentioned, so we have some data from national health accounts, but what is the contribution in investing in health from the private health sector? So that is the assess part. The second agenda is about the regulate. So we have to regulate the private health sector to be working for the public good of any nation, any public health system, or the country at large. So we have to regulate the private health sector. And the third one is the partnering. So you would partner with the private health sector by identifying who's doing what and engaging in different PPP types of arrangement. So assess, regulate, and partner. And we have this framework that was endorsed by our regional committee, our ministerial annual ministerial meeting, and we are looking forward to helping countries in doing so. I think for me, maybe a final word, if it is the time for that, to say that health is too precious to be only left for the public sector, let alone for a Minister of Health. So everyone has a stake in this and should play its role. And as a government, as any country, should have the tools and the mechanisms to engage everyone to ensure that the health agenda is on the table, as it's discussed at UNGA, but also is being translated in different policies and strategies. Thank you again for having me.
All hands on deck, in other words.
Yes,
Absolutely.
certainly. I mean, we have learned it the hard way. I mean, the cost of the pandemic has been gigantesque, so we have to do things differently moving forward. And I'm taking it really as a personal agenda. And I know that we are closing, but there, Richard Horton, the editor of the Lancet, again referring to the Lancet, he has written an article where he said one of his offlines, he qualifies that he looks at his generation as the generation of ghosts. Excuse the term. That as if we are just going through a crisis and then forget about it, and do not distill the lessons from that. And it is our generation that should break that cycle and do things differently moving forward. Thank you.
Thank you. And thank you, Dr. Shankar Seal, for the question. I want to make sure we have time for some audience questions in person. And if you could please introduce yourself and please keep the questions brief so that we can get to as many as possible. Let me take two in a row. So you, sir, and then we'll go there. Do we have a microphone? I think we do.
So I'm Dr. Naveen Thakkar, President of International Pediatric Association. My question is, are we doing enough in investing also for communication? And when I say communication, it's not only, awareness. We learn, as you said, hesitancy has persisted. We learned that, people are not, because people take vaccine. If you go to the vaccine hesitancy continuum, they take it because of demand is passive. It's not an active demand. They take because social copying. Their neighbor is taking, so they take the vaccine. And whenever you have all these misinformation, there is a totally push and that totally shift. So we learn everything, but are we doing enough? Whatever we are investing in discovery, making a vaccine, distributing, and we all realized that that was missing, and we are in the same position. We learned so many things in COVID. Are we doing enough investment, and what it will take? As my colleague from Path, they said, it's not a bilateral. Everyone has to come together. I'm on Devex Scientific Committee, and we also have collaboration of international vaccinology courses. If you map, there are hardly any courses in Asia or Middle East, and few in Africa.
So we'll go with,
are we doing enough in preparing our next generation
communication
for making them resilient to take vaccination? Otherwise, this will continue.
Thank you. And I think if you pass the microphone to the woman right there. Oh.
I know I'm sure you didn't see me. Hello, my name is Dr. Stella Bosire. I run a social entrepreneur in the continent around building communities, health leaders to be able to be at the leadership in terms of responding to either current or ongoing crisis. The one thing I've heard mentioned continuously in all of you is centering people in all interventions, whether diagnostics or response to vaccine. My only question is, why aren't we investing enough in community health workers, in community health leaders? Why is it that we talk about it up here, but when it comes to the grassroots level, we still do not build leadership, we still do not invest in them? And yet, the biggest lesson that we learned from COVID-19 is that we must center leadership, we must center resources, we must build capacity within the communities. Thank you.
Thank you. Powerful statement in its own right. So those two questions, how do we work on the communication front and the misinformation? And then how do we work from getting resources here to here? Tabani, you mentioned vaccine hesitancy. Let's start there.
Sure. I think one thing that I have learned is that if you ever say you are communicating enough, you are too optimistic. It is very unusual. As a leader and in my work as a professional, I have seen that we barely communicate enough. So the answer is no, we are not. There is still always room to improve. But what I would say is quite important is that communication must be tailored to the audience. And it must be responsive to the communities that you are engaging with. when we looked at the vaccine hesitancy challenges, they were very much in West Africa. And that's where it was really largely concentrated. And so how you do social listening and how you respond to that is extremely important. So there is a need to be context appropriate in terms of your communication and how you respond. Are we investing enough at community level leadership? Again, I'm afraid I'll say no, we are not there. But I'll say there's some good news. There will be, and probably not in my place to be announcing this, but there will be some announcement in Berlin at the World Health Summit about a significant investment on community health workers. And we are seeing this in countries like Kenya. President Ruto actually just committed to investing in 100,000 community health workers. And that's an important investment. So we are seeing the shift one country at a time. We'll get there.
I wanted to, yes, Thomas.
Yeah, so totally agree what was just said. Investing in communication and investing in hampering misinformation. I think the misinformation is as big as communication, and it's a big problem. Another point which always fascinates me, because I studied medicine at some point, how little education, for example, about vaccines and vaccination is going to medical students. It's and it's everywhere. It's not one particular country. It's really interesting, and I think people talk about healthcare worker on the front, but doctors as well should have a much better understanding. From an industry point of view, we are trying hard to break down the science. You know, everyone is now an expert after the pandemic in messenger RNA, but you know, the industry has to do their contribution to really make sure complicated science is well understood, because that is part of communication generating trust.
Well, we are out of time, but our panelists will be here hopefully for a little bit. So I'm sorry, I know we have a lot of questions. I have a lot of questions I didn't quite get to, but we do have another fascinating conversation coming up. So I do want to thank our panelists so much for the discussion. And next up, I'd like to introduce my colleague, Alex Cabaret, for a fireside chat on how to reverse the pandemic's impact on routine vaccinations in low-resource settings. Alex?
All right, thank you, Anna, and thanks to our panelists. Another round of applause for the panelists. Thank you so much for your time today. So, hi everyone, I'm Alex Cabaret. I'm head of partnerships at Devex, and we'll have kind of an SDG 17 conversation here, as we're welcoming Sabina Solomon from GSK, your head of global impact partnerships, global health impact partnerships at GSK, and Ariel Garten, who's head of partnerships management at Save the Children UK. So welcome on stage, and we'll talk about the power of partnerships today. And the panel introduced really well the issues around the setbacks in immunization that we've seen across the past few years, and notably due to COVID-19. We've seen outbreaks of cholera, measles in places that we have not seen in decades. And we're looking at the zero-dose children that Tabani referred to, and there are 8.7 million zero-dose children in Africa alone. And we're looking at a partnership here between Save the Children and GSK that's been going on for 10 years. The partnership goes beyond your organizations, right? Because it also involves community health workers. And you've reached 3.5 million children already in the past 10 years. And you just announced the renewed commitment for another 5 years for this partnership to have a bigger impact on zero-dose children. So without further ado, I'll ask you first question, Ariel. We'll start with you, if you don't mind. How do you reach children? How do you reach zero-dose children? And how does the broader partnerships angle plays a role in that work?
Thank you, Alex. And I think that was a brilliant summary. You've kind of done our job for us there. But so I think reaching zero-dose children, the first thing is that we think of them as children first, not a zero-dose child. A child who hasn't received their routine immunization is likely to also be a child who lives below the poverty line. It is possible that their mother will not have received adequate antenatal care, possible, and often also won't have access to clean water and sanitation. So we take a child first approach. And as came up in the panel just now, Save the Children will work through the health system. As Dr. Awad said, there's one health system, and that's how we approach addressing zero-dose children. And we want to understand deeply why those children haven't received their routine immunization. There is not one context that those 8.7 million children in Africa face. We want to know whether it's an issue of access, with the demand, supply, or some really complex intertwined factors like their past experience of a health system that might prevent them from getting their immunization. And Save the Children will do that anywhere, however hard the context is. And we've done that with GSK in Yemen and DRC, and we'll continue to do that.
Great, thanks. So how does the GSK is a big science and innovation company. You have lots of scientists, doctors in-house. How do you play your part in this kind of partnerships?
Yeah, well, I think to Ariel's point, it is all about the individuals and the communities, first and foremost. Personally, my personal background, my mother, when she was a child in Pakistan, she was very lucky to survive from typhoid fever. And 70 years on, when vaccines are fully available, immunization programs are fully available, it shouldn't be the case for so many children around the world today. I do think there is a really big opportunity, but also perhaps a responsibility, as I was hearing earlier on the panel, for organizations, whether private sector or not, to work together closely with stakeholders with a prevention mindset, so that we can really focus on listening to those who are experiencing these issues, who we can support, working together as one team. I think the private sector can bring a number of different things. Perhaps first, we can bring our employees' expertise and talented people to the partnership, working with Save the Children, for example. It's going beyond just passively funding. We do that. So, for example, we have a dedicated director for Save the Children account sitting in GSK, Matt McCallum, and my team. And he makes sure we really go beyond just what the basics might be in a partnership, working closely with your team, Ariel. I think that's really important. We also have 70 people over the last period of the partnership in GSK have brought their skills with them to go and sit in Save the Children and work with you, because it is much deeper rooted in GSK as a partnership. We also, many of our employees want to get involved. I'm sure it's the same in many teams. So over 70 different countries, we've raised more than £5.6 million fundraising that's gone to Save the Children, because our people are so devoted to working together. I do think this is really important, and I think that is a critical piece. I think in addition to that, we were able to be catalytic. This is something that we're really willing to do. We're willing to test, pilot, and where things work, invest and implement fully, working in countries we might not have done before without a great partner like Save the Children. And I think that's really important. An example might be where we invested in grant writing for the UN climate funding fund of green climate funds. Some of you might know. It's not much of it has gone to health today. So actually we did a little bit of seed funding, working with Save the Children, that hopefully opens up the opportunity for a £33 million programs that they can utilize, and others can come in and invest beyond. So that catalytic nature is something we can support. And finally on this piece, for us, it's stability. We know that sustainable change doesn't happen overnight. So we look to fund multi-year programs whenever possible. And so this is a 5-year commitment we're very happy to be making with Save the Children, so that then Save the Children can offer stability to partners, to governments and communities. And I think that's really critically important, because as Ariel said so nicely, we want to get in and listen to those people who are in the communities, who've got the answers, not us, and they can help us find the solutions that we need. We can only do that if we spend the time locally and the time doing it, setting ourselves up for success.
Great. Thank you. So it looks like there is a strong localization agenda as well in this partnership, and it's great to see that. So we've been able to reach 3.5 million children in 51 countries. Ariel, maybe you can tell us more about what you've learned through this partnership across the past 10 years, since you're also the co-chair of the partnership, and what's the next frontier?
Yes, it's hard to summarize 10 years of learning.
Maybe you can give us a couple of anecdotes.
Yes.
Yeah.
I think we've learned so much across the partnership, and you talk about those big numbers, which are incredible. I think it's incredible that we're talking about 10 years of partnership and another 5 years. I mean, for anyone who works with partners or with funders, to have that length of commitment is pretty unheard of, and it fundamentally changes what we can do. And I think it's one of the learnings we have at Save the Children is to increasing demand out of our partners. And I think it also strongly links to the localization agenda. We want to talk about sustainability, having long-term funding is part of that as well. I think we've learned what having a real impact really means, and it goes beyond those big numbers. It's about the long-term change we've been able to have by supporting advocacy work that's helped further the UHC agenda in countries and nationally. But I also think we've learned that, impact happens because of our partnership, but also just by people in communities. That's where impact happens. And I think hopefully a lot of people have heard this week, if we're going to achieve the SDGs, it's not going to be here in New York or in London. It's going to be by the communities who are addressing these problems. We've seen that, in the last phase of our partnership. Our work in Nigeria, my incredible colleagues in Save the Children Nigeria set up over 340 health groups with women and men, and monthly they learned about health issues, children's diseases. But it was then those groups, those individuals or collectively, who chose to take action. So I think our learning is about the partnership having impacts those people that have had the impact, and the partnership has enabled it. But I think the fundamental learning that we've had is, if we're going to tackle these big, complex problems that we've chosen to do, they're not going to have simple solutions, and it's not always going to be easy. But a kind of strong, stable, long-term partnership enables you to do that. And so the next phase of the partnership, we obviously have a continued commitment to ending preventable child death, but we're honing in on the issue of zero-dose children. And I think knowing the challenge that poses to children and society as a whole, that learning that it's going to be tough is a good one for us to keep thinking about.
Yeah, great. So it also has a transformative effect on the way you work with partners, and I guess the same with GSK, right? And so what do you expect from the next 5 years of the partnership? What's some of your hopes there?
Well, I think there's so much that's happened over the period with the 3.5 million children. There's also the most amazing community health workers who have been absolutely critical. And we've worked just in this partnership with more than 39,000 of them. And I think for us, they are the lifeblood who enables us to link to some real remote and nomadic communities. We've got some great experiences in the past that we're going to take with us to the future. So, for example, with our work in the Somali region in Ethiopia, we found it was absolutely phenomenal to be able to support the 8 warders or districts with the lowest immunization rates, because that is the biggest area of need. And we were able to make sure that we spent the time working with them to engage them and ensure inclusivity and equity. And those community health workers are phenomenal women, generally women, and they spend hours on the back of a boda taxi, if anyone knows what they are, clutching a vaccines box, going for hours in really difficult terrain, and then walking the last mile into the community before they have conversations, often supported and trained by the Save the Children locally. And I think from our learnings we take forward into the future is really about putting those communities front and center, making sure the community health workers are really listened to and engaged
throughout everything that we're doing. So in terms of moving forward, I think we are absolutely anchored in a prevention mindset, focusing on our joint ambition so that no child should suffer from a vaccine preventable disease. If we can even be part of that, that is something we want to do. We recognize there's lots of other efforts out there, so we want to be complementary to those and not duplicative. And I think that is really important. So we're focusing on where the major need is. As Ariel said, in Africa, as you said, the 8.7 million, a third of those children are in Ethiopia and Nigeria. So that's where we're spending our focus because that is the need. And obviously, we need to make sure that this is led by the community. So working in the community, with our stable relationships, spending time engaging with them. And early next year, we plan to launch an innovation incubator. So the idea is to get some grassroots companies and organizations and people coming up with the ideas. We're not going to have the ideas. They know what's needed. And actually, the problem's best looked at through the eyes of those people who are actually in the midst of those countries. So we're looking forward to those great ideas that we can support.
Yeah. And I guess the only thing I would add, and it builds on what Sabani was saying in the previous panel, is, you know, it's critical we do this now, not just because of the mixed picture that there is on zero dose, but also because of the climate crisis. And, you know, in the previous panel, you heard people talking about vaccination as a cost-effective intervention. I think I would argue it's not cost-effective, it's the best investment you can make, a critical investment you can make in a child. And at a time when we know the impact that the climate crisis will have on health, it's a crucial tool of prevention to prevent further outbreaks. So I think we feel real urgency at Save the Children and GSK to do this work now.
Well, congrats. It's great to see that you're renewing this partnership between your two organizations. This is fresh news, right? I guess you've announced it a couple of days ago. So it's great to be able to talk about it today on stage. Maybe one final word from each of you. What are your recommendations for organizations in the room who are looking to embark in such types of partnerships, or who would want to partner with your organizations?
I always say partnership ends up coming down to people. So you need to find people who you trust, who you can be open with, and people who share not just your vision, but your ambition. And if it feels easy, you're probably not being ambitious enough, is what I think. So that'd be my recommendation.
Totally aligned. I think I'll just add one point. Stay humble, stay listening, make sure that we recognize why we're doing this work and who we're working with.
All right. Well, congratulations for your work and your impact, and to the renewed commitment. Richard, you're between us and the lunch, so I'll let you close quickly. And thank you all for being here.
Many thanks, Alex. Also to Ariel and Sabina there, and a big thank you to all of our panelists, as well as to GSK for partnering with us on this event here at UNGA 78 this week. Thanks to my Devex colleagues, to all of our guests, and to everyone here in the room and watching from around the world for all your comments and questions from the audience. For our in-person audience, as Alex mentioned, I'd now like you to join us for a networking lunch, and stay tuned as we bring you a whole host of programming for our Devex at UNGA 78 Summit. That's both this afternoon from 12:30 Eastern and tomorrow afternoon as well. So thank you very much for attending this one. Thank you. Have a good rest of your UNGA week here in New York City. Thank you.